Hi students, I'm recording a lecture for this week. The topic is respiratory assessment. Again, a reminder for you to review the anatomy and physiology of the respiratory system. That's on pages 413 to 419 in your textbook. Just a brief review. The upper respiratory tract warms, moisturizes, and transports air to the lower respiratory tract where oxygenation and ventilation occur. Once you've reviewed the anatomy and physiology, you want to move on to the respiratory system focused subjective assessment on pages 419 through 426. You can use this to guide you in your interview with Tina Jones when you perform the subjective assessment on her respiratory status. This slide is a picture of the reference lines that you should become aware of and use when you're performing a physical assessment of the respiratory system. So you want to know, don't mind my dog, you want to know the mid-sternal line, and particularly the mid-clavicular line, because this is a landmark that we use in respiratory assessment as well as in cardiac assessment. The anterior axillary line is another reference line that you should be aware of. I want you to note the location of the mid-clavicular line. It starts in the middle of the clavicle bone and it runs medially to the nipple. So when you're asked in lab to demonstrate where that is, you can use those as your landmarks. The posterior reference lines include the vertebral line, the scapular lines, and the mid-scapular lines. And you'll notice that the location further along in the slideshow, when we review the auscultation landmarks for listening to lung sounds, would be you would be placing your stethoscope between the scapular line and the vertebral line. And that would allow you to hear lung sounds without them being obscured by the scapula bone. The rib landmarks should be reviewed as well. You'll notice that the first rib sort of hugs the underneath side of the clavicle. So the first intercostal space that you can really feel is the second intercostal space, which is the space between the first and second ribs. You can see that you cannot palpate the first intercostal space because the clavicle runs over that. We use the intercostal spaces as landmarks, certainly for auscultating heart sounds. So you want to get familiar with the different intercostal spaces. The clavicle is another bone that is used for landmarks, as we mentioned in the previous slide, and the sternum as well. The top part of the sternum is called the manubrium. That is the bone that in many people can be more prominent and sort of some people are known as sort of pigeon-chested if they have a very prominent manubrium. And the manubrium attaches to the sternum, and that is at the manubrial sternal intersection. And then there's the sternal body, and then the very tip of the sternum is known as the xiphoid process. And it is common for the xiphoid process to be palpable and even visible in very thin people, and certainly in young children, infants and children, it's very prominent. You'll notice that the ribs are made up of bone and cartilage, and the ribs attached to the sternum with with cartilage, and that is a common site for inflammation and pain often in adolescence. A reminder that the right lung consists of 3 lobes: the right upper lobe, the right middle lobe, and the right lower lobe. And the left lung consists of 2 lobes: the left upper lobe and the left lower lobe. The base of the lungs is the bottom of the lungs, and the apex of the lungs is the top of the lungs. This is the opposite in cardiac assessment. When we get to the cardiac assessment next week, the following week, you will learn that the base of the heart is really at the top and the apex is at the bottom, and that's because of how the heart sits inside the chest. But I want you to know the difference between the base of the lungs and the apex of the lungs. And next time I will want you to know the difference between the base of the heart and the apex of the heart. And you'll note that in order to listen to the right middle lobe uniquely, you would listen anteriorly under the right breast. This is a depiction, a visual depiction of the lower respiratory tract. And you can see it's actually of the entire respiratory tract, and then it's a magnified visual of the lower respiratory tract and a cross section, so that you can see the different various parts of the lung. And you'll notice that one of the features that I want to point out to you is the bifurcation of the trachea into the right mainstem and left mainstem bronchus. And one of the things I want you to notice is that the right mainstem bronchus is a gradual offshoot of the trachea, just sort of veering or bearing off to the right, whereas the left mainstem bronchus actually has a sharp angle off of the trachea. And this is why most aspiration pneumonias are on the right side, because it really, anything that one would aspirate into the trachea could easily fall into the right mainstem bronchus, whereas the left mainstem bronchus, because of the sharp sort of angle, it's less likely that anything in the trachea would end up on the left side of the lungs. So it's always good to just review the anatomy of the system that you are assessing, so that when you are assessing the patient both subjectively and objectively, you can be thinking in terms of the actual structure and function of the system. The upper right sided picture shows how the bronchi, which branch off into bronchioles, which are the smaller airways within the lower respiratory tract, and that those airways terminate in the alveolar sacs, which are very capillary rich, which is where gas exchange occurs. And in the cross-section picture in the lower right side of the slide, you can see how the lungs are wrapped by a visceral pleura, and then there is a parietal pleura outside of that, which lines the inside of the chest wall. And in between the visceral and the parietal pleura is what is known as the pleural space. It's a very small space where there's negative pressure in that space, and that's what keeps the lungs inflated, is that negative pressure. It's also an area where fluid can accumulate, and that can cause a lot of pain in patients. And also, if the pleural space is violated in any way, then the negative pressure is lost, and that can result in a collapsed lung. So again, breathing is an automatic process, and the main trigger for breathing is increased blood levels of carbon dioxide. The exception for that is in patients with chronic obstructive pulmonary disease, because patients with COPD often have elevated levels of CO2. They become sort of accustomed to those levels, and they lose the drive for respiration with increased levels of CO2. So what happens is hypoxia becomes a main drive for patients with COPD to breathe. And that's why we avoid giving excessive amounts of oxygen to patients with COPD, because we would cut off their drive for breathing. Certainly, there are things that can affect breathing. Medications can depress breathing, and anxiety can cause hyperventilation. In the process of inhalation, the diaphragm contracts and lowers and pulls the lungs down. That results in an elongation of the lungs, an increasing in the vertical diameter. And the intercostals open up, which also increases the parietal diameter. When inhalation occurs, there's the thoracic pressure is increased compared with atmospheric pressure, and approximately 500 to 800 mLs of air enters the lungs. Expiration is a passive process where the muscles just simply relax, and that is done automatically. There are conditions which cause exhalation to become an active process, and that is in conditions where there is obstruction. A common presentation would be in an asthmatic attack. Because asthma causes constriction of the lower airways, the bronchioles, it is difficult for air to exit the lungs. It's easier for air to enter than it is to exit. So in an asthma attack, one of the signs of respiratory distress in asthmatics is a prolonged expiratory phase where there is an active pushing or trying to push air out. And when a chest x-ray is obtained in a patient who's having an asthma attack, the chest x-ray often will be read as hyperinflated. In other words, the alveoli are hyper full of air because it's difficult for the lungs to expel that air. In terms of respiratory assessment, certainly the nurse needs to be aware of when a patient requires an urgent assessment. If a person appears to be in distress, is short of breath, has an elevated respiratory and pulse rate, and a lower oxygen saturation, the patient requires urgent assessment. And you would continue your assessment after those numerical findings by auscultating the lungs and then performing interventions. So you would try to complete your urgent assessment before you intervene. In addition to administering oxygen for patients with a low oxygen saturation, you may also have to administer bronchodilator medication. And positioning the patient with an elevation of the head of the bed is useful because when we review what we just discussed, which is how the diaphragm lowers in inspiration, by elevating the bed, we're giving gravity a chance to assist with that process. So it becomes easier for the diaphragm to move down with the addition of gravity in terms of having an elevated head of the bed. So whenever you are assessing a patient who is having respiratory distress, you want to provide a continuous assessment and likely be monitoring that patient as well for periods of time when you are not in the room so that they are not completely unattended. And you would perform your additional interventions, including decreasing anxiety and monitoring for improvement. So moving on to the subjective data assessment of a patient when you are referring to the respiratory system. Again, I remind you to review the pages 419 through 426 in your textbook, which is the process of subjective data collection for the respiratory system. And you can use that as a guide when you are performing your subjective data assessment of Tina Jones on your respiratory module. You want to make sure that you ask about past medical history, and you'll note that you'll be asking about past medical history in every body system. But you are thinking, whatever the patient tells you in terms of their past medical history, you are thinking about what of those conditions impacts your assessment of the respiratory system. So you're going to hear the same past medical history every time, but you'll be interpreting that data differently depending on what body system you are focusing on at that point in time. The same thing with lifestyle and personal habits. You want to know what her lifestyle and personal habits are, but you are taking that data and you are processing it in your head in terms of how that impacts her respiratory status. The same for occupational history, environmental exposures, medications, and family history. Once a patient provides you with information during your subjective data assessment, there are times when you should, as a health promoter, as a nurse, we focus on health promotion. That is a point in time where you can provide some education. You don't have to wait till the very end of the encounter. Nursing isn't really a linear process. Nursing diagnoses make us think in terms of linear, that we do things, in order. But the reality is, it makes more sense if someone tells you that they're smoking, that at that point in time is when you would try to, include some risk reduction or health promotion counseling around anything that the patient tells you during the subjective assessment that you consider an opportunity for education or for suggestions on how to improve their health related to whatever it is that they tell you. Common symptoms where patients will present for related to the respiratory system include coughing, productive or dry, chest pain, difficulty breathing or shortness of breath, wheezing, interfering with normal activities due to fatigue, difficulty breathing when lying supine, also known as paroxysmal nocturnal dyspnea, and other symptoms. So those would be the common presenting signs or symptoms from patients who have respiratory problems. Whenever your patients are telling you what their symptoms are, you need to consider their age. Certainly there are issues that present themselves as contributing factors when patient is more elderly. There are changes in their respiratory anatomy and function that occur with age, as in most body systems. And also cultural considerations. For example, there are some respiratory conditions that are more common in certain ethnic groups, and your textbook reviews those, so you want to consider that as well. In terms of an older patient, there are factors which can affect their respiratory status, including being less mobile. Their muscles, the muscle strength declines, and there's a fair number of muscles involved in respiration, so that is going to impact their breathing. The lungs lose that nice healthy elasticity as we age. There's decreased flexibility in the rib cartilage. The bone density decreases, so the bones are less strong. And many patients, especially women, can develop kyphosis or a hunchback, which can really alter the AP diameter of their chest, which can interfere with full expansion of their lungs. And as mentioned earlier, there are certain cultural groups that have more higher rate of certain respiratory illnesses. There are some ethnic variabilities with lung function and lung ailments. And certainly there are some respiratory conditions that are inherited. An example would be cystic fibrosis, which is an inherited genetic abnormality which affects the consistency of the respiratory mucus and results in obstructive lung disease. When performing the objective data collection, as we always do, you want to think in terms of what tools you will be using and the technique and the way that you will be approaching the assessment with your patient. Generally, with an adult patient, we perform a head to toe. So you would start at the top and work your way down. In pediatrics, we approach young children with a least invasive to most invasive approach. So you would do the least invasive techniques and end with the most invasive. We always begin with inspection. We discussed last week the 4 techniques associated with objective assessment: inspection, palpation, percussion, and auscultation. And this is the order that they go in. As I mentioned last week, percussion does not seem to be a common technique used by nurses. It's more of an advanced practice technique. I rarely see lungs percussed in my area of pediatrics, even by physicians. So it's probably something that is mostly done by pulmonologists or inpatient hospitalists who are taking care of very sick patients. So we're not going to spend a lot of time on percussion. But again, you note that we begin with inspection, which would be observing the patient breathe and looking from the beginning of the respiratory tract, which is the nose and mouth, and then looking at chest excursion and also looking for any increased work of breathing, retractions or sucking in between the ribs and the bones around the chest cavity. In terms of lung sounds, you could describe lung sounds as clear, vesicular, bronchovesicular, bronchial, coarse, crackles, wheezing, diminished, etc. So you want to review the appropriate terminology for the different types of lung sounds that you hear. After you've inspected and auscultated the anterior chest, at the posterior chest, you continue with the anterior chest, again considering the age of the patient and any cultural considerations. For example, I know in certain Asian populations, a common homeopathic or technique used by Asian people is to coin the chest when there is a respiratory condition, which is taking hot coins and rubbing them along the chest, which results in what looks like linear sort of bruising. And I wish I put a picture here, but I'm not sure if any of you have seen that. I certainly have seen that in my patients. It is not a form of child abuse. It is not abusive. It is a cultural moray. It is a long held belief that it is a method of helping the patient with whatever their respiratory condition is. There are a lot of people that believe strongly in herbs and foods, and actually onions are noted to be very useful for respiratory conditions, as well as garlic. And so some people will eat a lot of onions, or they will actually make something known as a poultice, which is a collection of sort of stewed or steamed onions mashed with like a flour, almost to make like a paste, and put that on the chest. So there are different things that you may see based on whatever type of patients you're exposed to, whatever geographic area you work in, or whatever cultural predominance is in the location that you work in. And I'd be interested to hear from you anytime that you've come across something unique that you've seen any of your patients do. If you'd like to share it with us in class or by email, I'd be interested to hear about some of the different things you've seen. So again, I want to remind people about the approach for auscultation. I tend to be a stickler for this because I see so many people not auscultating lungs the correct way, and it really annoys me. And actually, I had my physical the other day, and my doctor totally did not auscultate my lungs the right way. But as much as you can, you should really follow this technique. And you'll notice I like these pictures because they superimpose the bones so that you can actually see where your stethoscope should be and how that's avoiding the bony landmarks. So you can see on the anterior chest and the posterior chest where you should be placing your stethoscope and the order that you should be moving down the chest and going from side to side, so that you're comparing as you go down and you're listening over spaces that are not bones. And that's the end of the slideshow presentation. I hope that this is helpful for you as you complete your respiratory assessment this week. And if you have any questions or concerns, feel free to let me know. And good luck.